is a significant factor, but not the only one now. That is why the multi-parametric CT concept is more and more of a everyday practice and not just research, because the simple brain CT that we used to exclude bleeding, and that was the workhorse of stroke examination in a few years back, it's not enough. You can find a lot of things on brain CT, and especially in retrospect, when you have the perfusion and you have the diffusion on MR, and you go back to brain CT and you say, yeah, now I see there is discoloration, and you find all kinds of signs like insular ribbon and effacement of the sulci and all these kind of things that have unfortunately very low sensitivity. All those specifics so have very low sensitivity. Now, for the hemorrhagic, we won't have we won't go into the details. We will focus on the ischemic part, and we need all this kind of information before we make a decision actually for intervention, especially because thrombolysis or more or less the criteria are clinical based, but for intervention we need to have a good overview of the whole brain, intracranial circulation, and the neck arteries. That's why GE has proposed the fast stroke protocol that in its full implementation involves a brain CT without intravenous contrast, angiography, preferably in multiple phases, in arterial, venous, and late phase. We will see why this is important. And of course, brain perfusion. Yes, this is a no-brainer, I guess. We start with a brain CT without contrast to exclude the intracranial bleeding. Then we move on to the angiography of neck and cerebral vessel to find occlusion of large vessel and evaluate the collateral circulation in case of an occlusion, retrograde filling of the small vessels if the large vessel is occluded. That helps with the prognosis. Brain perfusion, of course, to evaluate the extent of the effect an occlusion has or an ischemia, because not always is due to, as we will see in a couple of cases, not always an acute ischemia is because of an acute occlusion. So the brain perfusion gives us information on the brain parenchyma, and it creates maps where we can evaluate the extent of tissue at risk versus infarcted tissue. Now, so if we want to model a physical phenomenon or a process, namely the perfusion, we go to, that's what the research does. It's doing studies, mostly on animals, and then tries to create a mathematical model that approximates the physical phenomenon. And because the reality is infinitely complex, it requires complex mathematics. But sometimes we can get along with simpler mathematics and get 80% of reality correct, or 90%. Is this enough? Then we go to the clinical studies and check how our different mathematical models depict or try to tell how it's going to be, try to predict the outcome. And if the simple mathematics work, then okay. If not, we move on to more complex. So in case of perfusion, and we will not go into the details, but think of two main types of algorithms, mathematical models that do not use deconvolution and those that use deconvolution. So out of these mathematical models come the different maps that we know, the different coloring maps, because the perfusion is just a CT, a low dose CT of the brain taken into several intervals. Out of Hounsfield information and time, we can create these maps. How we create them? With the non-deconvolutional approach, which is a simple mathematical model, much faster to calculate. Why it's simple? Because it assumes that the contrast bolus that reaches the tissue is exactly the contrast bolus that leaves the injector. So magically, the model assumes that magically there's an artery that goes from the injector directly to the brain tissue. Now, this is not true. But as we will see, it's not that bad. If we want to be more closer to reality, we have to use deconvolution, which actually means combination of two or more mathematical functions. So this has the possibility to include several parameters. And it does exactly that. It corrects for the ability to deliver contrast bolus into the supplying artery of a tissue of interest. So it's a more complex model. Before, like, I don't know, less than 10 years ago, it took more than 20 minutes to create the perfusion. Now, I think GE is using both deconvolution and non-deconvolution, depending on the different map, but everything happens in a few seconds. Now, the non-deconvolution model is also easier to understand. So on the y-axis is Hounsfield unit, on the x-axis is time in seconds, and this curve is the passage of the contrast bolus from one voxel. So all of these parameters are calculated for every voxel. That's why we have the map. So it is on the brain. This is one voxel at time 0, and at time 1, 2, 3, 4, and so on and so on. In our department, we take 17 samples of time spread into 50 seconds. So out of these, it creates a map pixel that has all these parameters. So it creates these different maps: the time to peak, time to drain, mean transit time, and this one, cerebral blood flow and cerebral blood volume. Cerebral blood volume is actually the area under the curve, and cerebral blood flow is the slope of the leading edge of the curve. And this is where miscalculation happens, because this is CBF is difficult to calculate. Without the convolution, this is just a slope. Now, in the convolutional approach, because the bolus undergoes a dispersion prior to its arrival. Yes, it meets several vessels along the way, so it's not exactly the concentration we injected. So we have the concepts of arterial input function and the time attenuation curve in the artery. So arterial input function is, think of it as the region of interest we set on the artery. Well, we'll show you on the demo. So this is the arterial input function. I mean, the values that are coming from the region of interest we set on the artery supply the values on the arterial input function. And then the values create a time attenuation curve, which is this one. Time attenuation curve has the artery, the vein, and the tissue of the brain tissue. So this is the benefit of the deconvolutional approach. We do not know the tissue time attenuation curve, but we can calculate through deconvolution. This is the rough mathematical model, how to write this, and in practice means this is a convolution operator. It's a fancy graphic here, but it means that, I'm sorry for that, that if we can measure the arterial time attenuation curve and we can measure the tissue attenuation curve, because we know on every pixel in the brain what are the Hounsfield unit per unit time. Then we can calculate the impulse residue function. And then we can calculate the CBF. Now, how do we calculate? The height of the curve is the CBF. The area under the curve is again the CBV, like the non-deconvolutional approach. The mean transit time is, we can calculate from the central volume principle. This is known from physiology. And now the Tmax, I didn't find an easy way to describe it because it's derived again from this deconvolution principle approach, but it is also calculated differently among the different vendors. So I'm just saying that although it's Tmax on not only CT vendors, but on the different software, so they might choose another algorithm. The good news is that in the clinical setting, we can use Tmax or mean transit time, first of all, to visually appreciate the penumbra without a result that is clinically significant. If we want to do research, of course, the Tmax, it's going to be different between the different vendors. But for everyday clinical practice, all methods that have CE or FDA clearance are good enough to have robust clinical findings, as we will see in the demo. Now, just to go through last part from the theory, blood flow, how it is defined, and it is measured in milliliters per 100 grams per minute, while the volume is milliliters per 100 grams. Mean transit time is in seconds. This is the permeability surface product. We don't use it for perfusion of ischemic tissue, but is used on brain perfusion of tumors or tissues. So it's used both in body perfusion in the liver, this map, and also in the brain, but not for the acute setting. It's part of an ongoing clinical research. Time to peak, and again, this is the peak enhancement index. So this again is for perfusion or the MR dynamic sequences that create this map. It helps to detect, let's say, to detect the malignancy. But for calculating the penumbra, it's these two, and then mean transit time or time to peak or the Tmax. Okay, after several clinical trials, and it's an ongoing research, researchers came up with some values. But again, the absolute values are, I won't say debatable, but there are several studies. Before we went to absolute values, now we have a tendency, especially for CBF, to go with relative values. So in theory, something below this one is considered pathologic, but this is the flow in the gray matter. The white matter has lower flow. So it becomes even more complicated to have absolute values. And what about to patients that have chronic microischemic changes? Is this normal? Probably not. But we have something to compare with, and this is the contralateral hemisphere. That is why the relative approach is better. So yeah, it's interesting. So as to summary for the theory behind perfusion, it's interesting because perfusion is based on several mathematical and physiological assumptions, but it works. All different algorithms, the different maps have advantages and disadvantages. The important is to get used to what you have. So after you have the first 20, 30 exams of perfusion, then you begin to have a feeling of how things go. What are the colors that look right and what shouldn't look right? It's maybe you would prefer if I would come up with some hard values that like this, but in reality is much more complicated. So it's more important the visual appreciation, at least in my opinion, in the clinical setting, in the emergency department. And even if you're used to, then sometimes vendors do changes, and it's for the better, and we have to be prepared to hop onto these changes, being in the background a better algorithm or in the foreground and a better interface that gives us more information. So I think the application specialists at GE are doing their best to say what's new, not only on ECR and RSNA, but when they come to the hospital. So try to get more of this opportunity. Well, not at least with COVID, but most probably we will have again the chance to see our application specialists and discuss with them what are best practices and even say our experience. So quickly on the scan parameters, this is standard CT. We go with helical scan in our department. Nothing really special here. Perfusion, it's an 80 kV, a lot of noise. The images, not these, the primary images as they come from the scanner is not for diagnosis. Low MA. You can go lower, I'll show you a case. Detector, if you have 16 centimeter, then it covers the whole brain. If you have 8 centimeter, center it along the basal ganglia, because this is where the most things occur. The most important ischemic changes, at least. Bolus, we use 40 milliliters for ml per second. In other departments, they use 50 milliliters with 5 ml per second flow. That would create a more steep bolus for arterial and venous. And in theory, it would give a better signal. But in practice, I think we've never missed a case with going with 40 milliliters. Now 17 passes. Do we have to wait that much? We can reduce, because what we need is actually the arterial curve and the venous curve, nothing more. So in this case, these are waste data, or at least almost waste. But if we stop the exam here, it would be enough. But some patients have bradycardia or insufficiency, cardiac insufficiency, and in some cases, even 50 seconds are not enough. So with 17 passes, I think we never had a failed map generation because of the time. So it's a compromise. As long as you have the arterial and venous curve, then it's enough. Okay. Okay, do we do perfusion first and angiography after or not? We do perfusion first, although there is no real evidence that the contrast circulating from the previous angiography it affects a baseline. But I don't know, in the initial tests, I've seen that the baseline was higher with angiography first. So we thought, okay, we do perfusion first. But that was a decision taken early on, and we haven't changed it. So I would say on most departments, they take angiography first and perfusion in the end. Now, the angiography we do at 100 kV, starting from the aortic arch to vertex, because it's important in case of intervention. The interventionist, they want to know what's going on here. Other major occlusions, stenosis, other sharp turns in the vessels. Is there tortuous? How is best approach to reach, for example, the MN or the basilar artery? So we need the whole area. And with 70 milliliters at 4.5, minimum delay in the aorta, the smart prep. We also do multiphasic angiography. The other two rotations, so this data comes from the angiography of the whole neck and the brain. The other two is simple 2 axial rotations in a delay. So we have delay between the first and second phase 10 seconds, and delay between the second and third phase 8 seconds. So it simulates this one, the arterial phase, venous phase, and then the delayed phase. Okay, what we can do to lower the dose, because this is a major thing here. There's a lot of series and there's significant amount of radiation. I mean, yeah, through the scan. So I'll just highlight some. So this is an exam, not on the same patient, but the brain doesn't change too much between people. I mean, the size of the skull. So we can assume more or less same dose for all patients. And anyway, the protocol doesn't modulate very much. Perfusion doesn't modulate at all, so it's the same dose for all patients actually. So I'm just going to show you the difference in the total dose if we do a couple of changes. So let's give it a second. And then it should be this one. Okay, that one. And then let's go to the second one. So I don't know if you see the numbers here. On the upper window, it's 3,200 DLP, and on the lower, the whole exam is 2,000 DLP. So what can we do to reduce? This is the brain exam. So here, what we can do a rather lower, we can lower the dose. I won't say low dose brain, but lower the dose. So I don't see the MA here because this is registered with the other one. But if I make it coronal, then no. Okay, so we can increase the noise index in the head CT. Why is that? Because it's not the only one. It's not the only exam looking at the brain. We will have the angiography and we will have the perfusion. And if it's bleeding, then we will find it even in a low dose scan of the brain. And that way, we go from 741 DLP to 586. So you can reduce or increase the noise index. But the other one is with the perfusion. Here the perfusion is with 150 MA, and here is with 80 MA. Now, if we go to 80, that's a bit too low, but you can definitely go to 100. And the maps would be, I think, indistinguishable from the two. I can load up this one with low dose. So low dose, I can load up the fast stroke. By the way, we'll give some tips along the way as I see them. Okay, so for example, this one is just a warning message that the multi-phase angiography have some gap because the radiographer didn't put the box, the scanning box, exactly where the first scan starts. So if it's a couple of millimeters off, then you get this, but it's not a problem. Actually, you should click OK here. And then here, OK, these little plus icons give you the phases. And this is the triple phase angiography. But you just, as long as these three are checked, you just have to click OK. Okay. Then let's go directly to the perfusion. Just to show you that the MA, 80 MA create nice maps. So not noisy. Well, there won't be so nice because there are some options here I would like to go through, but let's see. So these are the normal maps we are used to. Okay. Now, I have to go through the advanced settings here. That is, yeah. I'll do that in a minute. Okay, I'll just go very fast through this. So if we try to do the fast stroke examination through the packs, then there are too many series. That is why we have the fast stroke application on the AW server that combines all of them. So we start with a non-contrast CT, evaluate for bleeding and bright artery tine. In case of bleeding, actually, we have a new application, not so new anymore. We have an application that can segment the hematoma and even compare and give you the change % in volume of the hematoma and works very well in intraparenchymal bleeding. This is the application on AW. If we have time, maybe I can demonstrate. Now, this is the aneurysm segmentation application in case of an intracranial aneurysm that's the source of bleeding. But that's enough about hematoma. And then we can go to carotid's step to evaluate for significant stenosis in the intracranial or the neck arteries. We can use this one, the auto-vessel analysis, to create automatically segmentation, but I don't do it in this step because the most important is to see the colorways and the perfusion, as we'll see. So the stenosis, I go to the vessel analysis of the neck arteries software and do the proper measurement. But you can do it here if you just want to measure just one artery. It's working exactly as the carotid analysis, but only one vessel. Now, why do we need the 3 phases? Because here we have the possibility to check for asymmetries. on the vessels. Are the vessels enhancing on the late phase? Then this is a sign for collateral circulation. Is there part of the M1 or M2 missing contrast? Then here's the occlusion. The color whiz helps us evaluate all the three phases, combining them into one color map with two thresholds, one that separates the arterial from venous and the other from venous to the late phase. Yeah. We need sometimes to adjust this threshold to get more to the to get it solid red. Usually I almost never have to adjust this, but this I adjust a little bit just to get solid red on the main intracranial arteries. Okay, now a couple of things with color whiz. It needs significant difference in contrast between the passes. So if you get a warning that there is no change detected or something like that, then you have to increase the delay between the first and the second phase. I'm talking about this delay. So we had it before to 8 seconds and we had some problems. We changed it to 10 and then 8 seconds for the second and third phase, and this is okay. Now we go back again. And now the perfusion. We must never, well, it takes just a couple of seconds to evaluate the quality of the perfusion. And we do this with arterial and venous curves. And the arterial and venous curves should have a smooth rise and fall. And the arterial curve, of course, should come up first and the venous afterwards. Again, even smoother rise and fall as the arterial. And they have to be well separated from the baseline and well separated from each other. If you see an abrupt change that's something like this, then it's mostly wrong. It's usually the algorithm made a mistake, and because of patient motion, set the arterial region of interest into the bone, and then you have to change it. I'll show you how. Now these parameters, a lot of talk. We can talk about it, and these are in the current implementation only absolute values. Next version that's coming up will have also relative values, which is easier to change. But here, in practice, I haven't seen that with these settings that we missed a significant occlusion. As it is here, sometimes it underestimates the blood, the infarct core size, but not by much. In case of parenchyma that responds to ischemia with blood volume increase, then in these cases, it's the infarct core a little bit less. But in case that you have a big infarct core and the patient is not a candidate for embolectomy, then I think it does quite well. Tmax, I didn't have to change, and this is what we use, the Tmax. instead of in transit time. Okay, this is on the next page. This you always have to click. It's like a noise filtering that filters all these small islands of red area that is due to noise. So this is after to select only the connected components. If we don't do that, we get a lot of noise into the map. Okay. Yes. Now let's go here. What can we change into this one? And we don't have to do it all the time. We have to do it only once, because when we change the parameters here, we can save the settings as a default. So one thing we have to do, as we see here, the map is calculated also inside the ventricles. This is not appropriate, because the ventricles contain CSF and they will always have pathologic value. So we have to segment the ventricles. This is where the air threshold comes, and this is a bit of a misnomer. It should have been lower threshold, because if our lower threshold is to 20, then we compute the result, and then we will see that the ventricles are out. We have this at 17, but if you put it on 20, you're always sure that the ventricles are outside. The problem with having too high of a value of the lower threshold is that patients that have old infarcts or chronic microischemic changes, this part of tissue that has also low value will not be included. But again, think of it. We only need to know about the situation of the functioning brain parenchyma in the acute phase. And this normally has a Huntsville unit around 25 and above, 23 and above. So by setting aggressively our air threshold a little bit too high, we ensure that there is no signal from the ventricles and parts of the brain that are not important, I would say, for the evaluation of penumbra. But again, you can play with this and come up with a value that you want. The bone threshold, on the other hand, set to 100 is okay. Now, the other one, this one, if we set to yes, then it removes the bone from the CT images. It's not important. This last pre-enhanced image, you can set it here. Where does the enhancement start and where does it ends? In practice, it's not important. It increases a little bit the computation time, because now you have the computation of time starting from here and not from 0. But you will have exactly the same maps. That's the last image. Cranium removal, vessel exclusion. This is another interesting part, and these are the intracranial vessels in the circle of Willis and the falx cerebri. So 50 is a little bit too low. If you get it up to 70, that would again take a bit of brain tissue, but from areas of the white substance, not clinically relevant, I would say, for the perfusion defects, and then you will have areas that are relevant. Because if you have here, that's the choroid plexus, for example, this you cannot segment out. The more of these areas that you have, the more false positive results you get. And you know, okay, from anatomy that this is not real tissue that's infarcted, brain tissue that's infarcted, then you do get this and makes the map not so easy to go through. But another one that's even more important, it's this one, the smoothing radius. So this is to 3.5 and the map looks a lot grainy. So pixelated if you want. Turn this to 7. I think looks much better. So 2 changes, set the threshold to 1720 and the smoothing radius to 7. Resolution, it's 0.1. So if you set the higher, the faster the perfusion goes. But again, the map goes pixelated because it's the resolution. And the 2 others, hematocrit ratio and tissue density, these are constants. And it shouldn't be changed. I think it's for research purposes only. I've played a little bit with hematocrit ratio. I haven't seen some visual changes on the map. So this is how it looks. I think it's much better now. By the way, when do we know that the processing is ready? When the tissue classification becomes clickable. Now it's not, you cannot click it. It's not like the set symmetry button. Now it's ready. So now we know that we can go further. Okay, see the map, I think it's much better. And we can save the preferences here, save settings, that's it. We can go on to tissue classification. As we said, next, click this one. And then we have a nice map to display. So how do we export the maps? We can click the quick export and then click this one to save the regions of interest you have, and then click this. And it will save a series with current projection, that is axial series, with thickness here of 5 millimeters. And this is true for all kinds of exams or series. So if you have the colorways, you can again, 20 is too thick, but you can go to, let's just wait a couple of minutes, calculate. We can go, for example, to 10 and then quick export and then this one. So we will have axial projections, 10 millimeter thickness. Here, because of it is low dose, we can do a couple of things to make it look a little bit better. So here we choose the Smooth 3D filter. And then we change the window diagonally and we make it a little bit darker. So the vessels pop up. And to have a little bit of a, this is a vein, by the way, it's not the artery. So we can change it a little bit to have solid green and red. Okay, now. So these are some small tips to go, and what I want to see, because we're running out of time. I have several exams. In this case, it's a typical case with thrombus in the M1 on the right side. If we do the vessel analysis, we can also measure the thrombus. And as we would expect, large penumbra with a small infarct core. Typical patient for embolectomy. And after embolectomy, this is MR next day. So the patient went to Oslo, helicopter, embolectomy, returned to us after 24 hours, and there is only a small defect on the T2, corresponding very well to the infarct core. So we start to believe on perfusion. Now this is the demo 2. Let's go here. That would be that one. Fast stroke. This patient had hemiparesis symptoms early on, so sometimes they give thrombolysis, I think in the ambulance or right when the patient comes onto the hospital. Let's go to the perfusion. Yeah, so this sharp rise is most probably an artifact. So we would definitely need to come up to check this one. And I'll show you how to correct the artery, because most probably it's because of motion artifacts. It's on the bony skull. So when there is slight motion, the algorithm sometimes is confused between a bright vessel and the bright skull that's coming up suddenly into the field and moves away. So because of motions, I think it's a vessel. That's what it does. So show Roy, and no wonder it's on the skull. So how we can fix that? We can click modify Roy. We can go here to the arterial phase, right and left click. Right click goes more, increases the rank, left click decreases. And let's choose the basilar artery. Elliptic Roy, a small one, encircling the artery. And then click auto select, and this would find the best arterial input only within the circular Roy. And it does it very well. So it's not a point Roy. We see one point here, but it's actually a column. So if we go to column, columnar, see, it's not a single point, it's a column. That's why don't use regions of interest yourself. Click the show Roy, use this and click the automatic within the Roy you've already drawn. You can now remove this one. Right click delete, but it doesn't play. It's not that important. Now we have our arterial Roy. So here is before the compute. So here is with a mistake. We see that there's something wrong, and we can compute with the new data again. Well, this evaluation we have to do all the time. So the algorithms would get better and better, but there'll be several years that we think that we won't bother with this at all. because there are some real problems that is not sometimes it's not a problem of the algorithm itself, but because of the physiology. I'll show you in a while. So now this is the right map. So the other part of the brain has normal green colors, and there's blue colors on the affected side. Now, if we go to the tissue classification here, we see that the extent of infarct core is rather large. And actually, this implementation of AW has a tendency to underestimate the infarct core, but even into this, in this case, the infarct core is quite large. So not the best candidate for embolectomy. And actually, the patient within 12 hours had, I'll just show you the brain CT before. So you don't see a lot of infarction, but the follow-up CT, you see a large infarcted area with subsequent bleeding into the ischemia. So the perfusion was right once more, showing these parts as ischemic core. So that was interesting. Okay. Yes. So sometimes it's too late. This one, case number 3. Let me check how much time do we have. Okay. It's the opposite. Although we have large penumbra, we don't have large infarct core. And here, well, where's the bright artery, the left or the right? But if we move a little bit further on the Sylvian feature, we see the bright artery sign. This is for the residents. Don't forget the Sylvian feature. So it's here when we see mostly, but follow the MCA further, and you might see the bright time on the Sylvian feature only. So let's go to the perfusion. These are some motion artifacts on the skull, but well compensated. There is actually a motion correction going through to trying to align all these 17 series, and it mostly works. Yes, we are waiting. So as I was saying, with these 17 series, so here the patient had bradycardia, or the ejection started a couple of seconds later, as it should. So this is again within the 50 seconds of the uptake, and So it's a bit risky to cut down to 40 seconds. If we had only this part, it would have been okay, I think, only to 40 seconds. But if you move down to 35, then you don't have the proper curve, and the maps would lose specificity. So here is big penumbra, no chance, no question about it. Next. Here also a large infarct core. Yes. Number 4. Yes. This is what I was saying previously. It was this one that has a very large, very small, I'm sorry, very small infarct core. Because as we know from physiology, I go directly to the perfusion here. As we know from physiology, the brain that suffers from infarction has two possibilities: increase the pressure in the vessels systemically. That is why patients who suffer from acute infarction have hypertension, and do vasodilation on the capillary level. So to try to compensate for the reduced flow and the reduced flow actually, yeah, increase the mean transit time and reduce the CBF. So in cases where the penumbra tissue or where the brain tissue compensates for the reduced flow, the CBV should be the same or higher, the cerebral blood volume. So here actually you see increased blood volume. Let me just zoom in. If you check on the contralateral side, and when we go to tissue classification filter, there's very low infarct core, very small infarct core. So this is important. When we have CBV that's responding, this is good for the patient, not for the software, because it slightly underestimates the infarct core. What we can do, we can increase up to 1.2 here, let's say, get a little more. But now, according to newest research in the last 5 years, we've seen that the relative CBF, although physiologically doesn't really make sense, is the CBV that we have to monitor, but in practice, the relative CBF reduction of some percent, some people say 20% lower than the contralateral side, others says up to 40. Again, it's because they use different algorithms, settings, so it's a lot of talk. Seems to give a result closer to reality for the infarct core. Now, as I said, we have a new version already presented on RSNA, waiting for clearance and stuff for a new version of the AW that you can calculate the infarct core also with relative CBF or CBV. It's much more flexible. You can decide. Okay, now we move on. Yeah, a couple of pitfalls. These areas that appear, we always have to look for in the non-contrast CT, because doesn't take so much effort to identify that these are areas of chronic microischemia around the ventricles. Of course, these will appear as low with low cerebral blood volume, but this is not an acute situation. And if we have an old infarct, again, it will be colored with red. So we have to be always examine the map together with a native CT. Let's see. Yeah, I'll show you how to do it on next. You can have side by side. So instead of axial Tmax, you can click and it comes up a list where we can change to a non-contrast CT and see exactly where this area corresponds to. And if it's known gliosis, old infarction, or microischemia, we don't have to take it into account. Yeah, such small infarcts, and it's interesting that a young person had a infarction, but it can happen, and it's now detectable. Before it wasn't, but now it's detectable. In this case, also with non-contrast CT. Now it's too late. I mean, it's too far for embolectomy, and it's too late also. In the around the central gyrus, so corresponds with weakness. There is no apparent vessel occlusion or asymmetry, and this is the modified perfusion and correlates very well with diffusion imaging on MR taken on the next day. So perfusion is on CT is quite sensitive, not so sensitive as MR, but sensitive enough to have clinical decisions fast. Yeah, this is look for these kind of vessels that are colored in blue. They indicate delayed filling. So there's a first indication that something's wrong is going on here. Although we don't see the actual occlusion, but if you see asymmetrical, so here is bright red and here green and blue. So this asymmetry points to that something is wrong on the left hemisphere. And then we see more like a focal hypoperfusion in the central sulcus. Yes. And then there was occlusion of the internal carotid artery on the same side, but because of the normal or dilated now anterior communicants, there is passage of contrast enough to create hypoperfusion without large infarct core. Again, just to show how bigger sensitivity the perfusion has, the mean transit time or the Tmax. So here, nothing. on the collaterals view, nothing on the color whiz. The perfusion is showing a small defect on the frontoparietal area. Here we can see also, and sagittal helps us orientate, and then we can go back to the vessels and try to find for small occlusions. And with this in mind, we know that there's something wrong here. Then we can see a very small vessel that's occluded. So don't lose time. Go through systematically non-contrast CT, vessels, and then perfusion, but don't use 15 minutes to try to find a small occlusion. Go to the perfusion, go to the Tmax. If you find something like this, of course, see if there's big penumbra, infarct core or not. Then go back to the vessel analysis, and maybe you'll find the smallest of occlusions there. Yeah. Now, we have
30 minutes.
How much time do we have?
We have 30 minutes approximately, and perhaps we need a couple of minutes in the end for questions as well.
Yeah. So I'll just hop over in the case. Yeah. So the message here. I have another case that's even more important for the posterior circulation occlusion, but we can have partial occlusion effects. So we can have penumbra, but the vessels won't be occluded, but smaller in diameter. So it really helps to understand what is the effect on the parenchyma. If you see a vessel that's a little bit thin, then you don't know if it is a real functional effect. This you get it with the perfusion. That's why I insist to have both the perfusion and the multi-phase imaging. And with lowering the dose, you actually get more information with the same or even less dose. Yeah, this one, nausea, vomiting, and rapidly progressing into coma. This is interesting. So an experienced clinician, neurologist that has this kind of symptoms suspects occlusion of the posterior circulation, because there is no. It begins with actually general and mild symptoms, and then there's rapid progression, and there's coma. If there is occlusion on the MCA, people are hemiplegic, but they are conscious, while the posterior circulation occlusion, they lose consciousness because it affects the brainstem. And here we have the posterior cerebral artery on the left side that's mostly affected, and even so little. Here we can see that there is something wrong with the tip of the basilar artery. We can go to the carotids view and see beautifully the occlusion here. So goes without saying that this is a medical emergency. The patient can die in a few hours, and it's immediate action. So it's so easy to find it here. But if we go to the perfusion, there's an interesting twist. It won't happen all the time, okay? But let's see the perfusion maps that come out of this scan. Okay, let's look at the Tmax. What's that? It's red, completely red parenchyma. Big. It means that almost instantaneous passage of blood, and there is normal in the base of the skull. So there's something wrong here. So if we check on the region of interest, the curve, by the way, is perfect. But look, the arterial input is on the left vertebral artery, which is along the affected side, because we have the basilar occlusion here. So actually, the reason that everything else looks super normal and the, so to say, and the base of the skull looks normal is because we are comparing our baseline is on the affected side. So if you have strange maps, change the region of interest on the artery. So Sherroy, modify, go to the anterior circulation. For example, here on the anterior, auto select. Yeah, you have nice curve, arterial input, and then compute. And you will see immediately that the Tmax will change to the normal colors and depict the posterior circulation area together with the parts of the cerebellum with the colors of delayed perfusion. So I'll just, yes. That's a new input. Check the placement of Roy. If the artery is along the occlusion, is before the occlusion, maybe it's better to move it onto a non-affected area. So see here, normal colors as expected on the Tmax and blue colors on the base of the skull and the cerebellum. Okay. Now we have if we have time, now we have to move on to last case, the 8th, because it's really interesting. And if we have time, we go to case 7. So it was a weakness in left lower extremity, or nothing kind of really special or really specific with this patient's symptoms. Let's go to the collaterals view now, and we'll see on the early arterial phase that there is a rather large vessel going from the MCA back to the posterior fossa. That's not normal. Let's go to the perfusion maps. And actually, when we see the collaterals, we don't really think of it because we are concentrated to see on the vessels that are that are missing or vessels that are occluded. So maybe you don't see this at once. That is why I believe also on the I rely on the perfusion, especially on the Tmax side, which is really sensitive on flow disturbances. Not cerebral blood flow, but I mean, it's really sensitive on perfusion. That's the right term to say, and perfusion disturbances, both low and high, as we will see here. So here actually we have an area of hyperperfusion instead of low perfusion, as one would expect on Tmax. It's red. Red means close to zero, so it's really fast passage of blood into this area. So this is actually a type of shunt AV malformation of some sort that is shunting blood onto the left hemisphere. And it was most probably one of the secondary symptoms of the AV malformations, or it was just completely by chance that it was discovered. So yeah, that's a take-home message for demo 8. Not all perfusions are hypoperfusion. If you see, double check with Roy placement, and then go back to the vessel analysis or to the collaterals and see if there is an AV malformation. And if this is a rounded, small and rounded, or small and rounded, especially on the blood volume, and nothing else, then it's also an indication of a tumor, because tumors have high CBV. To see the tumor in the vessel analysis, we need delayed phase on a couple of minutes. So we won't see immediately. The tumor will not light up as we are used to in the contrast scan, because the CT, normal CT with contrast is after 3 or 5 minutes delay. But it will pick up on the blood volume and sometimes on the Tmax. Yes. You have time for case 7? Jon?
Yes, we still have a couple of minutes, so
okay.
Please go ahead.
Case. This is also an interesting case. So this is a 78-year-old patient with right-sided symptoms, and there's some chronic ischemic changes on the left hemisphere. If we go to the carotids, so there's normal vessels in the circular Willis. But if we go to the perfusion, we will see a defect. And I think on the left hemisphere. Yes, and then, okay. Well, wait just a few seconds so that the tissue classification is open. Double click. Yeah, no infarct core. So we have a large penumbra in the MCA territory, but we don't have an occlusion on the circular Willis. And it looks like there is an occlusion of the common carotid artery. Let me just lower. Here, there's just go to thin slices. So there is a subtotal occlusion. And actually, this was not acute. The neurologist knew about it. I don't know why the patient wasn't operated here. Maybe they were waiting for the operation. But what's funny is that the patient actually suffered an episode of low blood pressure. So the pressure here was low. So immediately the left side, or the side corresponding to the blood supply of the internal carotid artery on the left side, was affected. This is hemodynamic. So they didn't went to Oslo for embolectomy because there was nothing to remove from the intracranial circulation. They just increased the pressure and the patient recovered. And of course, there is further planning to operate the left carotid. But the last take-home message is that acute ischemia is not always due to acute vessel occlusion. This is a hemodynamic factor, and so check the whole story, not only intracranial anatomy, talk with a neurologist, and try to find a reason why things occur. Also in retrospect, because sometimes we have to be fast, but in retrospect, it's great to sit with a neurologist or the interventionist and talk about things. What was our initial impression, and what happened in the intervention, and what was the outcome of the whole procedure. So yeah, I guess that's it.
Excellent, Mikael. Excellent presentation. Do we have any questions for Mikael? If so the case, don't remember to unmute before you ask any questions. In the meanwhile, while we wait for questions, do you think that the Perfusion 4D software is quick enough calculating the perfusion maps, or?
Yeah, definitely, because here I've demonstrated several cases, one after the other. This won't happen in reality. So as you've seen, and it's running from a laptop, but if it's from the server or the dedicated G workstation, things go even faster. So it's several seconds for the whole procedure. Doesn't take long at all.
Do you always do both the multiphase and perfusion, or how do you decide?
I'm sorry, if we do multiphase and perfusion?
Yeah, both of them.
Yeah, yes, always.
Always, okay.
Yeah, and what you can do if you're dose aware, very dose aware, you can lower the dose even more on the second and the third uptake. So the first angiography could be full dose, and then lower the dose on the second and the third, because you are looking for delayed filling of vessels. You're not looking at the parenchyma.
And how much time do you spend on interpreting the multiphase images?
Well, actually, for the fast stroke protocol or the ischemia question, I use the AW. I don't. I just send the results to the PACS, the secondary captures. So I go directly to AW. I check on the non-contrast for bleeding, then go fast on the on the color wheels to check for asymmetry. If I don't find a big one, then I go to the perfusion after 3 minutes. Then I see for check for Tmax, and if there is not if there's not a big area of defect, then I go back to the angiography or the color wheels and try to find a small vessel that's occluded. But the whole process could be done in less than 10 minutes, I guess.
Okay. All right.
And I'm really pushing our residents to do the analysis. So all of our residents now are doing this. Because this is the future, the multi-parametric thing, both on CT and MR. And it's only dedicated applications that's gonna combine the whole story into something meaningful that one can go through in a few minutes. Yeah.
All right, thank you, Mikael. If no more questions, then okay. So now there's a question from Sunderbyn. CT perfusion also for patients with less than 6 hours since symptom debut? Question mark. Do you see the challenge?
Yeah. I don't decide in the first place if we would do perfusion. So the indication is from the neurologist, but so they have the whole idea of how much time did it pass, what are the actual criteria for thrombolysis and embolectomy. But yes, the 6-hour margin is not for the criteria. We do perfusion in almost all patients that have significant defects and weakness or ischemia type of defects. 6 hours, definitely not think that this is a. So we don't do only for those that are above the 6-hour window. There is another reason. We have to convince Oslo that, and I mean it in a good way, because we have to produce something that's reproducible. And the best way to say to Oslo we have a patient with occlusion is to do the whole set as fast as possible, diagnose, give the message to the radiographer, the neurologist, and then send the whole image set to Oslo if they want. Of course, not call the patient again back and forth. Let's do this, let's do that. We do the whole package at once.
All right. Thank you, Mikael. I think we have passed the time a little bit. So if no more questions, I think we will end this webinar. Thank you, Mikael. And as I said before, we have recorded a webinar and we'll send it out by email, I guess, tomorrow. Yeah. So thank you, everybody. And thank you, Mikael, for excellent presentation and demo.
Thank you. Thank you for the invitation, Jon.
Thank you. Thanks to all of you. Bye-bye.
Bye.